Hello everyone, I am Dr. Maitri Shankar, Associate Professor in Nephrology from Bengaluru, India. So I'll be sharing a case of infection-related glomerulonephritis and I've named it as when bacteria meets sugar. We have a 57-year-old gentleman who presents to the emergency department with progressive lower extremity edema and dark-colored urine for the past 5 days. He says, "My legs are swollen and my urine looks like Coca-Cola." Initially, he noticed mild facial puffiness. 3 days later, he developed swelling of both the lower limbs. On day 5, he noticed cola-colored urine and he visited our emergency department on day 6. He was a known diabetic and hypertensive since 7 years. However, of late his blood sugars weren't under control and they were running high. He also gives history of bilateral lower limb chronic venous insufficiency. He reports a painful skin infection on his right lower leg that began 3 weeks ago. He was treated with oral antibiotics by his primary care physician. He was a former smoker who quit smoking 5 years ago, and he worked at a construction site. On physical examination, his blood pressure was high. It was 168 by 94 millimeters of mercury. Rest of the vitals looked all right. He appeared alert, oriented, and uncomfortable because of the leg swelling. He also had mild periorbital edema. Cardiovascular system was unremarkable except for elevated JVP at 10 centimeters. He had 3+ pitting edema bilaterally up until mid-thigh. There was healing cellulitis on right leg with residual erythema and induration noted on both the legs. So here is the image of his bilateral lower limbs, as you can see. And there is a fundus photograph which is suggestive of diabetic retinopathy with multiple microhemorrhages in the retina. His labs showed serum creatinine of 2.8 milligrams per deciliter. His baseline was 1.1 milligrams per deciliter 3 months back. In between, there was no check of creatinine done. His BUN was 18 milligrams per deciliter, and he had a eGFR of 45 ml per minute per 1.73 meter square. Serum albumin was 2.9, potassium of 5.2 milliequivalents per liter, bicarbonate of 20 milliequivalents per liter, and WBC count was 11,200 cells per millimeter cube. His urine dipstick showed 3+ of albumin. 24-hour urine protein was 2.5 grams. Microscopy revealed dysmorphic red blood cells, which is pathognomic for glomerular inflammation. On the left, you can see phased contrast microscopy showing dysmorphic RBCs and acanthocytes. And on the right is dark field illumination showing acanthocytes again. So in the background of hypertension, hematuria, edema, drop in urine output, we made a syndromic diagnosis, and that was acute nephritic syndrome. So keeping acute nephritic syndrome in an adult diabetic male, we had the following differential diagnosis. Number 1, infection-related glomerulonephritis. Number 2, post-streptococcal glomerulonephritis. Number 3, C3 glomerulopathy. Number 4, IgA vasculitis or henox-choline purpura. Number 5, ANCA-associated vasculitis, mainly renal-limited microscopic polyangiitis or granulomatous polyangiitis. And finally, cryoglobulonemic glomerulonephritis. So I will shortly discuss the points in favor of or against these differential diagnoses. Keeping these differential diagnoses in mind, we sent out for additional tests. The complement levels returned with C3 showing low levels. C4 was normal. The pattern was consistent with alternative pathway activation. ASO titers and anti-DNase B was negative, so this ruled out post-streptococcal glomerulonephritis. For infectious workup, we had sent for blood cultures which returned positive for Staphylococcus aureus methicillin sensitive. C-reactive protein and procalcitonin levels were elevated. Autoimmune panel, ANA, ANCA, P-ANCA, C-ANCA, anti-GBM were all negative and cryoglobulins were also negative. Now, infection-related glomerulonephritis was the most probable diagnosis as the active infection was ongoing. We had active Staphylococcus aureus infection because of the cellulitis and bacteremia. Low C3 and C4 levels were normal. Nephritic sediment, adult male with diabetes. So all these was pointing towards IRGN. Coming to PSGN, points in favor were edema, cola-colored urine, and nephritic sediment. However, the infection was active and ongoing, but the ASO and anti-DNSB were negative. Usually, PSGN has a typical latency of 1 to 3 weeks after the onset of streptococcal infection. But however, here we had an infection which was ongoing, so it was clearly not post-infectious. And PSGN is more common in children compared to adults. Coming to C3 glomulopathy, the clues supporting C3 glomulopathy were isolated low C3 and nephritic range of proteinuria. C3 glomulopathy is usually chronic and it would persist despite infection resolution. So this could still be a possible alternate diagnosis if C3 continues to remain low despite treatment of infection. So we would plan to monitor C3 levels, and if it persists and if it continues to remain low beyond 8 weeks, then we would consider a diagnosis of C3 glomulopathy. Coming to IgA vasculitis, it usually occurs after infection and can cause hematuria and proteinuria. However, there was no purpura, arthralgia, or pain abdomen, and it is usually seen in younger age group. So less likely without the extrarenal vasculitic features. ANCA-associated vasculitis, it could present as rapidly progressive GN with nephritic sediment, like in this patient. However, P-ANCA and C-ANCA were negative and there were no systemic vasculitic signs. This is unlikely but could be a possibility if renal dysfunction continues to progress and the patient reaches a stage where he requires renal replacement therapy, and if the biopsy is suggestive of ANCA-associated vasculitis, of course. Cryoglobulinic glomerulonephritis may present with low complements purpura and neuropathy, but in here the C4 levels were normal and the cryoglobulin test was negative. Also, there was no hepatitis background, HCV was negative. So probably unlikely in this case. So keeping acute nephritic syndrome in mind and the rapid raise of serum creatinine from a baseline of 1.1 milligrams per deciliter to 2.8 milligrams per deciliter within a few months' time, and also with the presence of dysmorphic RBCs, we decided to perform a kidney biopsy. So this was what the kidney biopsy looked like. On light microscopy, there are features of exudative endocapillary proliferation, mesangial hypercellularity, lobular accentuation of the glomerulus, and neutrophilic infiltrations are also prominent. On IF, IgG glomerular staining is seen. IgG is stained along the glomerular capillary basement membrane and also in the mesangium. Also, we can notice codominant C3 glomerular staining. The patient's clinical presentation, lab findings, and kidney biopsy findings were all consistent with infection-related glomerulonephritis, probably secondary to Staph aureus bacteremia from his recent cellulitis. So the key clinical features of IRGN in this patient was the timing, as it occurred during infection, unlike PSGN, which has a latency of 1 to 3 weeks. IRGN is again more common in adults with diabetes, immunocompromised state, and IV drug abuse. And on lab parameters, we noticed low C3 and positive blood culture. C4 was normal and negative for ASO and anti-DNSB. The patient received antimicrobial therapy with amoxicillin clavulinate for methicillin-sensitive Staph aureus bacteremia. He received a 6-week course given the persistent bacteremia risk, and also MRI was suggestive of early osteomyelitic changes. He also received conservative wound debridement. The wound care was advised until complete healing. His blood pressure was controlled with ACE inhibitors. Volume overload was managed with loop diuretics. He was advised sodium restriction and also to maintain blood sugars under strict control. His renal functions were monitored. We did not provide any immunosuppression as it is not indicated in IRGN. Just the treatment of underlying infection is sufficient for treatment of IRGN. Also, we referred him to a podiatrist for diabetic foot education. The patient showed gradual improvement in kidney functions over 3 months following completion of antibiotic therapy. As you can see, serum creatinine levels reduced to 1.4 milligrams per deciliter and 24-hour urine protein reduced to 1.1 grams over 24 hours. And C3 levels had normalized by week 8. So the key learning points from this case. Consider IRGN in adults with acute kidney injury, hematuria, and recent or active infection, especially with diabetes or immunocompromised state. IRGN occurs during active infection, while PSGN follows a latency period of 1 to 3 weeks after streptococcal infection resolution. Low C3 with normal SIBO suggests alternative complement pathway activation. It can be seen in both IRGN and C3 glomerulopathy, so it is important to follow up C3 levels until it normalizes. Appropriate antimicrobial therapy is the cornerstone of treatment. Immunosuppression is rarely needed in IRGN and may be harmful. We usually consider immunosuppression only if it is a crescentic IRGN. However, the data to support the use of immunosuppression even in crescentic IRGN is limited. Most patients recover kidney functions if infection is adequately treated, though some develop chronic kidney disease depending on the baseline kidney health. So this is the last slide with the summary. IRGN is an under-recognized cause of acute glomerulonephritis in adults with active infection. Early recognition and treatment of underlying infection are essential for optimal outcomes. Maintain high clinical suspicion in patients with nephritic syndrome and concurrent infection, especially with Staph aureus or Streptococcus species. Pursue infectious workup aggressively. Send for blood cultures, urine culture, serologies, and imaging to identify the causative organism and infection source. We had a patient with dental caries presenting with IRGN. Another patient had chronic osteomyelitis, and we had one other patient who had infective endocarditis who had presented to us with IRGN. Kidney biopsy should be done when diagnosis is uncertain. It definitely helps differentiate IRGN from other glomerulonephritis and guides management decisions. Thank you.